Hi, good morning. My name is Dr. Jason Waspy. I'm an associate professor at Harvard Medical School. I'm a cardiologist at Mass General Brigham, and I'm the chair of New England CEPAC. I'm grateful to all of you who have joined us today. This is really an extraordinary topic that is of tremendous importance to the delivery of healthcare in our country. Today, we are going to discuss semaglutide and tirzepatide for obesity, effectiveness and value. And this really is going to struggle with very profound questions of health policy. Obesity is a problem that's worsened over many decades. Poor cardiometabolic health is perhaps the most important healthcare issue affecting populations in this country. Drugs they're not new, but they've been repurposed for this. They appear very effective, relatively cost effective, but it's not clear how the country as a whole can afford it. So I'm looking forward to a very robust and a vigorous conversation today. I'm going to start by introducing a lot of my colleagues on the New England CPAC. And just to make sure I don't forget anyone, I'm going to do it in alphabetical order, starting with Professor Rob Azeltine. Please just introduce yourself and say if there's any updates to your conflicts.
Good morning, Rob Azeltine, Professor and Chair of Behavioral Sciences and Community Health at the University of Connecticut Health Center. There are no updates to my conflicts.
Thank you, Rob. Dr. Austin Fracht.
Good morning, Austin Fracht. I'm Chief Research Officer at Joint Commission, and I have no additional conflicts of interest to raise.
Thank you, Austin. Rebecca Kirsch.
Good morning. I'm Executive Vice President of the National Patient Advocate Foundation, and I have no updates.
Thank you. Dr. Steve Kogan.
Good morning. I'm Professor and Vice Chair at the College of Pharmacy, Department of Pharmacy Practice and Clinical Research, University of Rhode Island, and I have no updates to my conflicts of interest.
Thank you. Don Kreis.
Good morning, everybody. I am Don Kreis. I am the utility ratepayer advocate from the state of New Hampshire, but I'm really here on the New England CPAC because I have the honor of having raised to adulthood a young woman who lives with cystic fibrosis.
Thank you, Don. Thanks for joining. Dr. Julie Coopers.
Hi, everyone. Julie Coopers. I am the VP of Clinical Consulting at Alera Group, and I have no updates to my conflicts of interest.
Thank you. Dr. Tara Lavelle.
Hi, everyone. I'm Tara Lavelle. I'm Assistant Professor and Health Economist at Tufts Medical Center, and I don't have any updates to my conflicts of interest.
Thank you. Dr. Kim Lentz.
Good morning, everyone. Kim Lenz. I'm the Chief Pharmacy Officer for Mass Health and Assistant Professor in Family Medicine and Community Health at UMass Chan Med School. I have no updates to my conflict of interest.
Thank you. Dr. Aaron Mitchell.
Hi, I'm a medical oncologist and assistant attending at Memorial Sloan Kettering Cancer Center. I have no conflicts of interest.
Thank you. Dr. Stephanie Vale.
Good morning, Stephanie Vale. I'm a board-certified psychiatric pharmacist and professor of pharmacy practice at the University of New England, and I have no updates to my disclosures or conflicts.
Thank you. Joe Porter.
Good morning. I'm Joe Porter. I'm the Chief Strategy Officer at the New Hampshire Center for Justice and Equity, and I have no updates to my conflicts.
Thank you. Dr. Jim Rebitzer.
Thank you. I'm a health economist and the Wexler Professor of Management at Boston University, and I have no updates to my conflicts of interest.
Thank you, and it's Jim's first CPAC session, so we're delighted to have you on the panel. Dr. Joe Ross.
Morning, everybody. My name is Joe Ross. I'm a general internist, a professor of medicine and public health at Yale, and I have no updates to my conflict.
Thank you. Dr. Jason Schwartz.
Good morning, everyone. I'm Jason Schwartz. I'm an associate professor of health policy and management at the Yale School of Public Health, and no updates to my conflicts.
Thank you. And I think if I haven't missed anyone, I think I haven't missed anyone. I also have no updates to my conflicts. Did I miss anyone? I don't think so, right? Okay, thank you. All right, so next, I'm going to call on individual patient and clinical experts to introduce themselves and declare any potential COI. We have a COI disclosure policy, and all speakers have complied with that. So let me start with Joe Nedklowski.
Thanks, everybody. I'm Joe Naglowski. I'm president and CEO of the Obesity Action Coalition, which is the patient advocacy group in the obesity space. We have about 100,000 members, 90% of whom have raised their hands saying they live with obesity. I have no personal relationships, but as you see disclosed on the slide, we take lots of support from a variety of the evidence-based industry around obesity. Maybe the most important disclosure that is not on this slide is that I am a person living with obesity and have utilized both the medicines, obviously not at the same time, but utilized both the medicines that we're going to talk about today. Currently on one, only switching between the two because of cost purposes.
Thank you. We will talk more about that for sure. And we're delighted to have you join us. So thank you for joining us. The next speaker, Michelle Tedder, I believe is not joining yet. So she's going to join later. I will just, for that reason, I'm going to read her disclosures. She does not have any disclosures aside from being an Obesity Action Coalition board member. She is the director of chronic disease for the Black Women's Health Imperative, and we are delighted to have her expertise as part of the mix today. She's going to join later. Next is Dr. Melanie J.
Hi, good morning. I'm Dr. Melanie J., professor in the Department of Medicine and Population Health. I see patients at the VA. I've done like 3 hours of consulting for Novo Nordisk like a year ago or so. Yeah, not about the treatments or anything.
Okay, no, thank you. Thank you.
In full transparency, I do a little consulting, but that.
Thank you. No, we appreciate these disclosures and appreciate your expertise and appreciate you joining us. Dr. Alexa Trio.
Hi, good morning, everyone. My name's Alexa Trio. I'm a primary care physician at Beth Israel Deaconess Medical Center here in Boston. I am also obesity medicine certified and direct and embedded primary care weight management program. I provide both consultative services and support both my colleagues and the practice as a whole to deliver high quality evidence-based obesity care. My only conflict is that my spouse works for a company that was recently acquired by Lilly a few months ago.
Thank you. Thank you for this is such a range of expertise, and we're so grateful to have all of you with us. So just as has been referenced, because of the nature of what we do, we just would ask that any other speakers, including PRT, the Policy Roundtable participants and individuals making public comments, announce any financial relationships with industry or other potential influences on judgment when they speak. We plan to present this information publicly on the slides. So with that, I'm delighted to introduce the ICER's president and chief executive officer, Sarah Emlott.
Thank you, Dr. Wapsie. I really appreciate it and appreciate everyone being here today. And I do think overcoming some technical difficulties, Michelle is with us. And Michelle, if you just want to say a quick hello to the audience, that would be wonderful.
Hello, everyone.
Perfect. Michelle, thanks for being here. Jason did a great job introducing you, but we'll hear a lot from you today, and we appreciate you joining us. As Jason mentioned, I'm the president and CEO of ICER. It's my pleasure to be with all of you today. I'm joined with several esteemed colleagues from the ICER side to walk through our evidence presentation today and our health economics presentation. Dr. David Rind, our chief medical officer, served as the senior management team lead for this project. Dr. Grace Lynn, who's our medical director for HTA and also works at UCSF, is the evidence author for this presentation today, this report. And Ujung Lee is our lead economic modeler. She's our associate director for health economics and decision modeling, and she'll talk us through the cost effectiveness model in a little bit. Next slide. We always want to make sure that we are centering the lived experience of patients when we kick off one of these meetings, because we all know that we can get pretty wonky pretty quickly talking about issues of comparative effectiveness and cost effectiveness and budget impact, but we will not lose sight of why we're here. We're here because there are medicines to treat this intractable disease that are very effective. Well, we'll talk about that for the first time. And what we know is that our understanding of obesity has evolved. And we're also going to talk about that today. But this quote that we heard from one of the patients who engaged with us during our review really summarizes this well. I've struggled with weight pretty much my entire life. I was always the cute little chubby kid and, grew into the overweight adult eventually. Through my life, I tried many, many things to lose weight. If you put a checklist of different diets that have been out there over the years, I could check all the boxes. Over the years, I developed a lot of internalized bias and the noise externally around diet culture that it's our fault. It wasn't until I got a really caring healthcare provider who saw me and understood that obesity was a disease, and then helped me to understand that that's what it is. That theme is going to run through today. Obesity as a chronic condition, treatments for that chronic condition, and how we're ensuring affordable access for patients. Next slide. A typical ICER meeting, we are often looking at drugs before FDA approval. Sometimes we're looking at drugs for rare conditions. Sometimes we have an evidence base that leaves us with a lot of questions. We're having a bit of a different vibe today. These are drugs that have been on the market for a while. We have a pretty robust evidence base that we're going to dive deeply into today, and we have some modeling about what this means for cost effectiveness for population health. But we are still going to be asking ourselves questions, and the system is going to be asking itself questions about the trade-off of risks and benefits. How does this fit into other treatments that we might offer people living with obesity? And how are we going to afford this as a healthcare system? And so we're going to bring our best selves to this conversation, focused mostly on solutions today, because we can all admire this problem for a while, and we have, but it's time to start thinking about what are the practical solutions for affordable access. Next slide. We're doing that in the context of not great news. The news right now is showing us what we are all starting to feel in our healthcare premiums, in running small or large organizations, in managing health systems, in managing health plans, in managing pharmaceutical companies. The cost of care is only going in one direction, and it's up. I was recently participating in the Massachusetts Healthcare Cost Trends hearing, and the leader of the largest health plan in Massachusetts talked about trend right now, 14%. That's a direction that is unsustainable for our system. And if I sound like I'm ringing the alarm bell, I am. We all need to be moving urgently and acting with purpose to address the sustainability of our healthcare system. And what we spend on drugs is part of that conversation. So that's another theme that you can expect to come through when we get together for the policy roundtable later today. Next slide. We do this work at ICER because we care both about the patient in the room with their doctor needing access to a new therapy or a new treatment, as well as everybody else in the healthcare system who needs support from our healthcare system. And that means that we do not forget the unseen people in our system who are harmed when we spend more for value than we can afford. And so again, another message that we'll make sure that we bring back today is the population health imperative of delivering affordable access for patients and their families and the entire system, so that we all can we have enough money to pay for all of the priorities that we have for our healthcare system. Next slide. All right. Many of you know who we are, but for those tuning in for the first time, ICER, as an independent research organization, we convene the New England CEPAC, as well as 2 other independent appraisal committees who come to this public forum to talk about the reports that we generate on new drugs. And we'll talk about the cost effectiveness. We'll talk about the comparative clinical effectiveness. Our New England CEPAC, as you heard during the introductions, bring tremendous perspective and expertise to this conversation, for whether they're practicing physicians, consumer and patient advocates, or health economists and methodological experts. We're very grateful for their participation. Next slide. We don't just make everyone else talk about their potential influences on judgment. We talk about them for ourselves as well. I invite people to dig deep into ICER's funding. We list every organization that has given us money over the last 12 months on our website. You can see here that the majority of our funding comes from independent philanthropy. Any money we do take from manufacturers, health plans, provider groups is siloed to support our policy leadership forum, where we hold a summit each year with representatives from those industries to try to tackle a big issue that we're facing as a system. It will surprise no one that the last report was on how to pay for GLP-1s for most patients, which some of you attending today participated in that report. You can check that out on our website. I also invite people to check out our own policies on conflict of interest if you're interested. Next slide. We have a pretty long process to get to this moment. It takes us about 8.5 months to do a review. We start with scoping. We spend a lot of time working with different stakeholders, including the manufacturers, including the patient groups, to make sure that we're answering the right questions. We're looking at the data the right way while we develop our economic model, while we make our conclusions about the comparative clinical effectiveness of new therapies. We also are deeply grateful for the expert review that we received during this report development, that their names are listed here. Thank you again. The draft report went up for public comment. If you're interested in who provided comment and what we did with those comments, we are transparent about that. It's on our website, and you can see our response to all of the comments that I received. Again, I have deep gratitude for those who spend time to provide comments to us. It strengthens our work. The evidence report went up just a couple of weeks ago. That's the basis of the conversation today. We will be finalizing that report based on what we do today. We'll talk at the end of the meeting today about some of those timelines to expect, but today is that structured voting session that we will have with our New England CEPAC a little later. Next slide. We'll talk about value today, and we're also going to talk about affordability. If there's one theme that I think is going to run through our conversation today, it's balancing the idea of thinking about things from a long-term value perspective. How much are new interventions helping a population of patients over their lifetime versus the money that our system has right now to afford treatment? But if we're thinking about anchoring a conversation on long-term value, this is your 10-second primer on our value assessment framework. We analyze the things in the clinical trial data and in real-world evidence when we have it that tell us how much better this drug is for treating a particular condition. Does it have fewer side effects? Does it improve quality of life? We also measure how much it costs and how much it potentially saves the health system. We also make sure through conversations with patients, their families, clinical experts, that we understand the things that are harder to quantify about the potential value of a medicine, benefits beyond health, special ethical priorities, meeting unmet needs, addressing stigma and bias. These are things that we will also talk about today that we gathered from our conversations with different stakeholders in the development of this report. Next slide. You've made it to the end of the introduction and the convening. In just a moment, you'll hear from Dr. Grace Lin, the presentation of our clinical evidence. After that, Dr. Lee will talk us through the economic model that she developed, and we will have a public comment session and conversation. After the lunch break, the New England CEPAC will come back to deliberate and vote on what they've heard, both from our report and from the public comments and conversation. After another short break, we'll convene again for a policy roundtable discussion where we're really grateful that both manufacturers are participating. We have two fantastic clinical experts who you'll be hearing from today, two outstanding patient advocates who will be with us throughout the day, as well as two representatives from the payer community to really tackle what the policy solutions are in front of us to ensure affordable access. We will end with some reflections from our New England CEPAC, and we expect to adjourn around 4 o'clock Eastern today. Thank you all for your attention and for being here with us today. It is my pleasure to hand things over to Dr. Grace Lin.
Thank you, Sarah. As Sarah said, I'm Grace Lin. I'm the Medical Director for Health Technology Assessment at ICER and also a Professor of Medicine and Health Policy at the University of California, San Francisco. Next slide, please. This presentation and the report were made possible by the excellent work of our team, Shaharyar Mohammed Fahim and Finn Raymond at ICER. These are listed our financial disclosures on the slide. Next slide, please. So as you know, obesity is a chronic disease that affects more than 40% of Americans. The etiology of obesity is complex. There are both genetic and environmental factors at play that cause the disease. We know that there are higher rates of obesity in Black and Hispanic Americans, and that Asians may have effects of obesity at lower body mass index. We know that the impact of obesity on health is large. More than half of people living with obesity have a comorbidity, for example, diabetes, high blood pressure, heart disease. And some studies have shown that severe obesity can shorten life by nearly 14 years. Obesity, we know that obesity is costly to the healthcare system, with an estimated $172 billion in direct medical costs annually related to obesity. Next slide, please. Obesity has systemic effects on the body, as you can see here from the diagram. It affects everything from mental health to the cardiovascular system to the musculoskeletal system, as well as endocrine and kidney issues. Next slide, please. We are grateful to have had the opportunity to speak with patients and patient advocacy groups, and we heard a lot of very interesting and profound effects, profound things about living with obesity. The impact of obesity on both patients and the healthcare system is huge. We talked with patients and patient advocacy groups who told us that one of the most common issues that people living with obesity face is what they call food noise. And this is intrusive thoughts about food, obsessing about food restrictions, and this colors their entire relationship with eating and with food. We also heard that weight stigma is associated with low self-esteem and resulting in high rates of depression and anxiety, and that people living with obesity often face delayed diagnoses when their symptoms were blamed on their weight, and also delays in receiving preventive care. The healthcare system is unprepared to manage obesity as a chronic disease. We heard that often providers fail to broach treatment until complications occur, and that people living with obesity had a very difficult time finding comprehensive care, which may include obesity medicine specialists, primary care physicians with expertise in obesity, managing obesity, appropriate dietary education, appropriate psychological support are some of the things mentioned that were difficult to find. We also heard that people living with obesity have tried many treatments throughout their lifetime and lose and gain weight several times throughout their life. Next slide, please. Obesity is typically defined by body mass index, which is a measure of weight relative to height. A person is considered overweight when their BMI is greater than or equal to 25. They are considered having obesity at a BMI of greater than 30, and severe obesity over 40, a BMI over 40. Treatment of obesity starts with lifestyle modifications, including modification of diet and increasing physical activity, often in a structured manner. These measures typically result in 5 to 10% of loss of body weight, but this loss of body weight can be very difficult to maintain over the long term. There are also medications to treat obesity, some of which we'll talk about today. The existing options include older stimulants, combination oral medications such as Qsymia or Contrave, and the GLP-1 receptor agonists and the dual incretin GLP-1 GIP receptor agonists, which we'll talk about today. Bariatric surgery is also a very effective treatment for obesity, but many people do not wish to undergo surgery. Next slide, please. So today we'll talk about 3 interventions. We'll talk about injectable semaglutide or Wegovy, oral semaglutide, which has been approved for type 2 diabetes, but not yet for obesity, and tirzepatide or Zepbound. We compared these interventions with lifestyle modifications and with each other. Next slide, please. So our objective today was to evaluate the efficacy of semaglutide, both subcutaneous and oral, and tirzepatide added on to lifestyle modification, compared to lifestyle modification alone among adults without type 2 diabetes, who are seeking medical management for weight loss, and who are overweight with at least one obesity-related comorbidity or adults who are living with obesity. Next slide, please. We had quite a few clinical trials in this space. As Sarah alluded to earlier, this is a space with a lot of evidence already published. We had multiple trials, key clinical trials for weight loss, and you can see those listed on the left-hand column, including one trial, SURMOUNT-5, that was a head-to-head trial of tirzepatide versus injectable semaglutide. We also looked at key clinical trials for cardiovascular outcomes, and those are listed on the right-hand column, and I will talk about those in more detail shortly. We did conduct meta-analysis for the STEP trials for weight loss for injectable semaglutide, and for 2 trials, SOUL and PIONEER 6, for cardiovascular outcomes for oral semaglutide. Next slide, please. Key outcomes that we sought out evidence for include weight loss, health-related quality of life, metabolic parameters like blood pressure, blood sugar, lipids. We also looked for cardiovascular risk reduction data, impact on other organs, such as the liver, with metabolic-associated steatohepatitis, obstructive sleep apnea, osteoarthritis. And we also looked at the harms of these 3 interventions. Next slide, please. Let's delve into the results. So here we have this table summarizes the result, the weight loss from baseline compared with placebo for each of the interventions. We can see that each intervention results in substantial weight loss from baseline. This is a percentage weight loss from baseline, with tirzepatide having the greatest effect of people losing almost, on average, almost 18% of their body weight, compared with 13% for injectable semaglutide and 11.5% for oral semaglutide. We also note that many participants in the clinical trials lost more than 20% of their baseline body weight, with almost 60% in the tirzepatide trials doing that versus approximately 30% in both the oral and injectable semaglutide trials. Next slide, please. These are results from the head-to-head trial of tirzepatide versus injectable semaglutide. Again, we see that participants on tirzepatide on average had more weight loss than with injectable semaglutide, with many participants losing 20 to 25% of their body weight. Although I will note that the percentages of people losing 20% or 25% of their body weight looks to be a little bit smaller than what was in the trials versus placebo. Next slide, please. We looked for results for health-related quality of life, and the trials found that injectable semaglutide and tirzepatide improved SF-36 scores, the physical component score, but had lower scores on the mental component score. They were still better than placebo, but they were a bit lower than baseline, and it's not entirely clear why that's the case. There's also a quality of life measure specific to obesity called the IWQOL light CT score. And for all three medications, participants in the trials had improved IWQOL light CT scores. More participants taking both oral and injectable semaglutide achieved health-related quality of life improvements that exceeded the minimum clinically important difference compared with placebo. Next slide, please. Let's talk about the cardiovascular trials. So as I mentioned before, we looked for impact of these interventions on cardiovascular outcomes. And from these trials, we see that all 3 agents lower the risk of major adverse cardiovascular cardiovascular events. However, there are limitations to the evidence base. For injectable semaglutide, you can see here that injectable semaglutide in the SELECT trial reduced the risk of MACE by 20%, but this is in patients with known cardiovascular disease. We think that the benefit may extend to primary prevention. It's reasonable to assume this because there are improvements in cardiovascular risk factors, but we don't have direct data for primary prevention. For oral semaglutide, the data are limited to a trial in the type 2 diabetes population at a dose that is treatment for diabetes, 14 milligrams, not the 25 milligram dose that is proposed for treatment of obesity. For tirzepatide, this was a trial, again, in patients with type 2 diabetes with cardiovascular disease. It was also compared with dulaglutide, which is another GLP-1 receptor agonist, not versus placebo. So while we know that tirzepatide may reduce the risk of major adverse cardiac events slightly versus dulaglutide, although that wasn't a statistically significant result, we don't have a direct comparison with placebo. And so with these indirect comparisons, it's difficult to know relative to each other which of these drugs may have maybe better or comparable or better in terms of cardiovascular outcomes. Next slide, please. The clinical trials also looked at other outcomes, and I will note here that these are just things that were measured in clinical trials. There are a lot of ongoing trials, and there may be other effects that were not measured in clinical trials. So we saw that treatment with semaglutide, both forms or tirzepatide, improved systolic blood pressure, hemoglobin A1C, lipids, waist circumference, and decreased the risk of developing diabetes. Treatment with injectable semaglutide has been studied in terms of kidney disease, and it decreased the risk of developing severe kidney disease, improved knee pain and osteoarthritis, and improved liver fibrosis. And treatment with tirzepatide has been shown to improve obstructive sleep apnea. Next slide, please. In terms of harms for these medications, the majority of participants in all the trials had an adverse event. Most commonly, these were gastrointestinal side effects. Although most people had some sort of side effect, serious adverse events were much less common, about 10% for the semaglutide trials, 5% for tirzepatide, and discontinuation was low, less than 10% in all trials. Serious adverse events of special note, including gallbladder and pancreatic adverse events, were rare, and death was very rare in these clinical trials. Next slide, please. Here I've listed the harms from the direct comparison trial of tirzepatide and semaglutide, and you can see very similar results. Most people had some adverse events, mostly gastrointestinal events. Next slide, please. You can see here that serious gastrointestinal adverse events were less than 5%, but a little bit higher in the tirzepatide group versus the semaglutide group. This is what we also saw in the clinical trials, but interestingly differs a little from what we heard from clinical experts and people living with obesity, is that tirzepatide seems to be a bit better tolerated than semaglutide. Next slide, please. Some uncertainties and controversies. We talked a bit about the uncertainty of cardiovascular benefits and particularly for oral semaglutide and tirzepatide, where we don't have direct data in the population of interest. We don't know about long-term weight loss maintenance and discontinuation, including whether if someone discontinues the medication, whether retreatment is as efficacious as initial therapy. Longer-term harms. For example, we've been hearing a lot in the news about sarcopenia or the loss of muscle mass, and we don't know whether that has clinically important effects. We don't know if there's a long-term risk of thyroid or pancreatic disorders based on the mechanism of action of these medications. And we need additional data on subgroups, particularly in the lower BMI groups. As I mentioned earlier, Asians tend to have, as a group, tend to have metabolic effects of obesity at lower BMIs. And we don't, because these trials enrolled patients with BMI above 30 or 27 with a comorbidity, we don't have a good sense of whether these are equally effective in people with lower BMI. Next slide, please. Some benefits beyond health and special ethical priorities. We know that access to obesity medications is challenging. New options and more effective therapies may be beneficial in closing the treatment gap. As I mentioned earlier, Black and Hispanic Americans have a higher prevalence of obesity and so may derive greater benefit from treatment. While treatment may not have immediate effect on caregiver burden, in the long term, there may be significant impact on caregiver burden if some of the complications of obesity can be prevented. The oral formulation of semaglutide offers an additional option for those not wanting to use an injectable medication. Next slide, please. So some additional insights from our discussions with patients about treatment with the GLP-1 receptor agonists. We heard that treatment with GLP-1 receptor agonists has been, quote, life-changing. It helps manage the food noise and relationship with food, and the efficacy is greater than other treatments that have been tried before. But we also heard that there are significant barriers to treatment, which I'm sure we'll hear a lot about today, including insurance coverage. We know that less than 20% of employers covered weight loss drugs in 2025, and Medicare is barred from covering these drugs for weight loss only. We also know that treatment differs by race and ethnicity. For example, we heard that Black women are less likely to be offered treatment. And the financial barriers are huge. Although there are direct-to-consumer offerings from the manufacturer with discounts to about $500 a month, that's still not affordable for many people. And there's a lack of patient assistance programs for these drugs, unlike many other drugs. Next slide, please. We appreciate the public comments that we received when we released our draft evidence report. We heard that we should consider conducting a network meta-analysis, including all 3 interventions. However, we felt that the relative effects of each drug is well known from the clinical trials, and a network meta-analysis would not change our conclusions. We also were asked to consider using adjusted weight loss data rather than unadjusted data, but we did not find any evidence of subgroup effect by baseline BMI, and therefore we thought the unadjusted data, which I presented today, would be the most appropriate for comparison. Next slide, please. In summary, I think we've seen that semaglutide, both injectable and oral, and tirzepatide, in addition to lifestyle modifications, are effective for weight loss compared with lifestyle modifications alone. There is cardiovascular benefit. We've seen for injectable semaglutide, there's a little less certainty for the cardiovascular benefit for oral semaglutide and tirzepatide in this population that we're talking about. And that makes it difficult to compare the 3 drugs without better data. All the drugs appear to improve quality of life. Injectable semaglutide and tirzepatide have also been studied in other conditions outside of just weight loss. And the harms appear to be mainly gastrointestinal and are mostly tolerable. Next slide, please. So in summary, we gave evidence ratings both for these all interventions, both versus lifestyle modification and then versus each other. So first, I'll cover the evidence ratings versus lifestyle modifications. So we gave all 3 interventions in adults with obesity or overweight with comorbidity compared with lifestyle modifications an A rating, which indicates a high certainty of substantial net benefit, which I think, in terms of the amount of weight loss, each drug compared with lifestyle modifications shows. Next slide, please. Compared with each other, we had a little less certainty. So for tirzepatide versus injectable semaglutide, and for tirzepatide versus oral semaglutide, we gave a PI rating, or promising but inconclusive. This means that we have moderate certainty of a comparable small or substantial net health benefit, and there's a small but non-zero likelihood of a net negative benefit. And this is primarily because of the uncertainty in the cardiovascular data. So it could be that, tirzepatide is perhaps worse than injectable semaglutide in this population. We just don't know because we don't have that direct data. In terms of oral semaglutide versus injectable semaglutide, we gave an evidence rating of C-, which equates to a moderate certainty that the oral semaglutide is comparable or inferior to injectable semaglutide. And again, this is mainly driven by the uncertainty we have in the cardiovascular outcomes data, and the fact that oral semaglutide appeared to have slightly less weight loss than injectable semaglutide. So I appreciate your attention, and I'm happy to take questions.
Thank you, Dr. Lin, for that amazing presentation. We really appreciate your expertise and your thoughtful commentary. Let me turn to our panel. Stephanie, Dr. Vale.
Thank you. And thank you for that excellent presentation. I have a question for you. So as you noted, there's a large co-occurrence between obesity and psychiatric conditions. And often these are conditions that are treated with antipsychotics, such as bipolar disorder or treatment-resistant depression. Do we have any evidence about the use of these medications in people on highly metabolically insulting antipsychotics, like olanzapine and quetiapine, as well as those that are metabolically insulting when they're used as adjunctive therapy to highly serotonergic medications, so like the partial agonists like aripiprazole?
That's a great question. We don't, though, those people were excluded from clinical trials, and they haven't done clinical trials in that population. You would suspect that, there might be some effect, but how large an effect is not known. I will, that's just from the evidence. I will ask our clinical experts to weigh in to see if they have had some practical experience using these medications in the populations you mentioned.
I can just say anecdotally, we do use these medications in patients who take the atypical antipsychotics or other weight promoting psychiatric medications, and they seem to be effective. But of course, it's anecdotal.
Yeah, we have in the VA, we have a lot of patients with severe mental illness, and these medications have been helpful. And I believe there are some studies looking and seeing that they're effective for weight loss and glycemic control in this population, but not a lot. We've actually been trying, a colleague of mine has been trying to get funding to do more of that.
Awesome. Thank you so much.
Thank you. That was super helpful. Do other experts want to weigh in on this, or should I move to the next question?
This is Joe. From the patient perspective, I think it was a great question, and it maybe speaks to a bigger issue that we've thought about around obesity and care in general, and that we don't always wrap around the mental health care that's necessary for people with obesity as we move forward in this. And so when we talk maybe in the policy roundtable later, maybe we can address that, because I think that's one of the components of this moving forward. We can look at the data, for example, around people who've had bariatric surgery, and we do see higher rates of self-harm, et cetera, in that population. And so what are we doing to make sure we don't see those similar instances of harm in this population? And again, I think that's the bigger wraparound system care, maybe more than the medicine itself, but the care people need wrapped around addressing their obesity and the complex issues associated with it.
Thank you. And I do think I'm sure that Sarah's going to want to talk about that in the policy roundtable later as well. Are there any other questions? I definitely have lots of questions myself, but I just want to defer to others. Here we have, I see one now, Steve Kogan.
Yeah, thanks. And thanks for that great evidence presentation. As those of us who are older know, this has been a therapeutic area for which medications have been snake bitten, going back to fen-phen and Redux, and just a whole legacy of drugs that have had problems, Meridia, et cetera. And I think maybe even clinicians had that in the back of their mind with these products. And the report does allude to some uncertainties about long-term safety, but yet all of the products were rated at an A level as well. But my question is for the experts, do we feel like we're pretty sure that there aren't any longer-term safety concerns with this class of medication?
I mean, we're always waiting for the other shoe to drop. I totally hear you. And being in this field for 20 years, I'm always worried. And yet the long-term data, I mean, SELECT trial had at least 4 years of follow-up, and then we only see improvements with certain outcomes. We started looking careful in certain cancers or pancreatic cancers. I recently saw an article, we were worried about, anion, which is like a form of monocular blindness, and now some studies are showing that it actually is improved, even though we think that rapid decreasing glucose, might make people more vulnerable. And so we keep looking at them with looking at these things that could happen, but at this point, not yet. We have not seen any sort of major safety signal that I've been really concerned about. And just back to the mental health, there had been worries, for instance, about worsening suicidality and stuff, but the overall in the general population, actually mental health seems to improve. But if I have any patient who has any risk of suicide in that individual, I screen them, we make sure we follow them closely, because in any individual person, it can increase their risk for mental health conditions, and probably has to do with just the major life changes that happen once you lose a lot of weight, and what your expectations are, and relationships, and a whole sorts of other things. But at this point, as a population, we haven't seen any major safety signals.
Thank you. That was super helpful. I think David, from ICER, do you want to make a comment on this?
Yeah, I just because whenever we're talking about the ICER evidence ratings, I tend to jump in. So, when we're talking about net harm or net benefit, we have to imagine a side effect that offsets a 20% reduction in cardiac events, the #1 cause of death in the United States. That doesn't mean that when we treat tens of millions of people with these drugs, it's not going to turn out that there are bad things they do that we don't know about right now. It just means that there'd have to be a lot of those bad things to offset a 20% reduction in the #1 cause of death in the United States. And that's how we got to our A rating.
Thank you, Dave. That's super helpful. It's also, I think, as Sarah referenced at the beginning, this is an unusual ICER meeting in this setting, that this is already in clinical practice. Some of these medications have been used for a number of years, and as such, we have more safety data than we typically have when we're deliberating. And I presume that was part of the A rating. Joe, I think you have something to say.
Yeah, just on this issue of safety, and I agree with everything that's been said. I think we have one complicating factor around that as well, and just make sure everyone's aware of it again, maybe for the policy discussion later. But as you know, either compounded or outright bootleg versions of these medicines are being produced and used by large numbers of people, and we don't actually understand, are they safely produced? Are they safely created? Things along those lines. So actually, even moving forward in the future, I think if we start to see safety signals, we're going to actually have to have a real conversation about, is that for the actual medicine, or is this for the versions that some of us, you could literally go online and probably have delivered to you here while we're on this call today, right? Kind of thing. And just so it's a real issue that makes that conversation even more difficult.
No, thank you, Joe, for raising that. And I guess aspirationally, I hope someday that we have fair access to medications to the point where we don't have people going to the bootlegged version that we can't trust. So I appreciate the importance of your comment. Are there additional questions from the voting panel? I think I see Stephanie, Dr. Vale.
Yeah, thank you. One more question from the psych side of things. Have you seen, and I guess this is maybe more for the clinical experts, have you seen many people in long-term recovery having reemergence of some of their cravings or symptoms of their substance use disorder as you switch the medications or change the medications? Is that something that you're thinking about in that patient population?
Do you mind to just clarify when you say long-term recovery, do you mean from obesity or from substance use disorder?
From like either alcohol or a different substance use disorder. So like, I'm building on some of the emerging data around how these medications might help with that. And so I'm wondering if in people that have obesity who are in long-term recovery, say from alcohol use disorder, if you're noticing situations where a patient might be in the trough of their GLP-1 agonist and having emergence of some of those symptoms.
I can answer first, then Melanie, please feel free to also chime in. I have not seen that. I do see it more so related to related to their obesity. So the cravings for food, sometimes after a patient's been doing really well, it slowly starts to kind of creep back in. I do see that sometimes despite being on a stable dose. I haven't seen any sort of recurrence or recrudescence of substance use while someone's been in remission for a long time on the GLP-1 therapy.
Yeah, I mean, the substance abuse indications are very new, and really we only have the data for alcohol, and I don't have a lot of experience. We have a lot of patients at the VA who have substance abuse who are on the GLP-1 medications. I will say, though, when I found my patients go into rehab or get treatment for substance abuse, they tend to gain a lot of weight. For various reasons, also because the food they serve at those places is horrendous, but also just the stress and replacement with other behaviors. And so I think it's could be potentially a great tool to kind of co-treat both issues.
Thank you. And I think Austin, Dr. Frack, do you have a question? You think your hand went up and down? I just want to make sure I didn't miss you. Okay, I guess not. Julie, Dr. Coopers.
Thank you. And thank you, Dr. Lin, for your presentation. My question is around the discontinuation rates. I believe in the evidence you stated there was about a 10% discontinuation rate in the trials, but I'm wondering if you have any comment or the clinical experts have any comments of what you're observing patients with their discontinuation rates once starting these medications.
Yeah, thank you for the question. So there are some real-world evidence studies that show higher rates of discontinuation, although it's a bit unclear. These studies were done during periods of drug shortages, so it's unclear whether discontinuation was from side effects or whether discontinuation, was from drug shortages. I will defer to Dr. Trio about their clinical experience.
I mean, so of course, like we work very closely with our patients and in weight management clinics. And so we probably have I have a discontinuation rate probably closer to probably even a little higher than they do in the clinical trials, actually. No matter what you tell the patient about this being a long-term medication, everyone thinks that they want to go off of it and try, or a lot of people do. In real world, they're much higher. Up to 70% of people are not on the medications at 1 year. And I think that's going to be a big limiting factor. Gayosin et al. Recently did a chart review looking at causes of people going off the medication. And about 48% were either due to the shortages or due to cost, which means the other half are due to other reasons, whether it's side effects, which is probably, I think, around 14 or 15%, or, that they don't want to be on medicine long term, or a lot of them were unexplained causes. So I think we need a lot more studies about how to support people to be on the medications longer. And I think also that relates to who's in a clinical trial. There tend to be people who have a lot more support, who may have different social barriers than people who do not participate in clinical trials. And I think we need to have enough support for people when they are on these medications to make them as effective as they are in clinical trials.
It's also, just my anecdotes as a cardiologist, it does come up in the initial prescription decision. Like, aside from the issues around clinical intolerance or cost, patients one question I find is that, if I start this, do I have to continue it for life, is often something that comes up as a practical matter when people are deciding to initiate these medications.
And I think that's related to weight stigma. You don't get that same thing with blood pressure meds. They don't wonder why their blood pressure is going to go back up when they go off the blood pressure medicine. whereas they wonder that with the weight management medicine.
Yes, that is, it's certainly more common with this. That's a very thoughtful point.
If I might add,
oh, right.
if I might add just one more thing, I do think, especially in the primary care world, just the lack of capacity to follow up these patients appropriately really contributes to discontinuation. I think a lot of providers don't have the space in their clinic to follow these patients regularly. Many practices don't have pharmacists to help. And so if you're not being followed closely, your medication may not be titrated appropriately, patients may not experience the weight loss they're hoping for, so they may discontinue because of that, or they're not having adequate, coaching or support for side effects. So I do think it's something that we really need to also think about if we're going to treat more people with these medications, as boosting support within primary care to do this work.
Yeah, it's such a thoughtful point. For all the difficult healthcare delivery issues we're struggling with today, there's also the question of provider capacity and the limitations in the workforce that we've seen in the last few years worsen. Michelle Tedder, I think you have a comment or a question.
Yeah, I think it might be a combination. I'm just curious to know how much data do we have in terms of when we do wraparound, so to speak, with people living with obesity, being on the medications, and having longer term behavioral health support. What does this look like, or what could this look like? Because I think that in my own journey, I find that having all of those things, particularly the mindset piece, and that takes time. Because as you're transforming physically, you're also transforming emotionally and mentally around this, and even in terms of practical things to do in order to maintain the success. So I guess my question is, do we have enough data that really drives home the point that if we have the intersection of medications, we've got access to that, we have access to physical movement, and we also have access to the behavioral health piece longer term, because that's what really takes a lot of time to kind of put all of this together for long-term success. What does that look like? And is it there? Or do we still, I think I know the answer, do we still need to really advocate for more of those approaches at the intersection of these interventions?
Such a good question. I'm going to direct it probably to the clinical experts, unless Grace wants to weigh in as well.
You're singing my whole research agenda at the moment. So I totally agree. We need to figure out how much support people need on the medications, how much support and education our healthcare providers need. My friend just called me this morning, was started on tirzepatide and has nausea. And she said her doctor would not give her an anti-nausea medicine, which is like because he said he's never had to do it for anybody. And it's just, and so that's a threat of her being able to stay on that medicine if she's so nauseous. So there's so many factors. I totally agree with you.
Thank you, Dr. J. Joe, I think you have a question or a point.
Yeah.
Do you want to make?
Yeah, just to pick up on Michelle's comment is, there are people and there are studies being done now around programs that are meant to support people on this journey and are meant to keep them on medicine. Remember, there are other programs out there that are being intentionally designed to try to get people to come off these medicines too. Again, maybe in absence of data, we can have that conversation later. But some of the early data we're seeing is quite promising, right? So there's programs out of the state of Connecticut, what they do with their state employees, where they're talking about 90% of people staying on medicines, right? Kind of thing. You also see a program out of AT&T that has a similar, these well-designed wraparound programs are keeping people on medicine. So I really do think that the people coming off is a systems problem, right? Have we created the system to wrap care around folks? Maybe less of medicine problem, right? The medicine itself, but the actual system that's wrapped around the medicine, again, speaks to the, how we treat obesity differently than we do any other condition, as mentioned earlier.
I agree.
Thank you. And I think we have 1 minute left. So this has been such a robust conversation. I just want to make sure I'm not missing anybody. We do have probably time for one more question. And if I don't have one, I'm going to sneak one in from me. And this is, I guess, more for the clinical experts and for Dr. Lin. It's partially the cardiologist. I'd love to hear more about the thoughts about primary and secondary prevention of cardiovascular. This is remarkable in my community that you're seeing differences in cardiovascular endpoints, at least with one of these medicines. But to the extent that where does primary prevention, secondary prevention, where is that line? You know, obviously someone's had a myocardial infarction, that's secondary prevention, but to the extent that people may have a little bit of calcium on CT scans or on coronary calcium scans, how we should think about that as a primary, secondary prevention. I know this is like a tricky issue because the guidelines kind of hedge on this. They're probably purposely not clear, but just would love your thought about when we think about using these medicines for primary or secondary prevention of cardiovascular illness.
I will say, do try to use that asymptomatic coronary calcification to try to get approval for
Right.
for the GLP-1s. Not always successful. But I think everything, we know that theoretically it does make sense that it would be, helpful for primary prevention. So if there's any sort of wiggle room or any evidence I can try to use to convince the insurance company to cover the drug, I will.
Yeah.
Even if they haven't had an actual MI.
Yeah, I mean, right, the effects on the cardiovascular effects seem to be independent of weight loss. And we know that there are GLP-1 receptors on the heart. But we've also been burned in the past that even if there's biological plausibility that we think it should work for primary prevention, that doesn't mean then when you actually do the study, which will take 10 years, that you actually will find it. So it's hard to say one way or the other definitively, but it makes sense. And if you're getting other benefits in the meantime, if you know that if you treat sleep apnea, or you treat liver disease or other things, you're going to have longer term health benefits, then you still have other reasons to put people on it.
Right, right.
So,
Thank you all for your I think one more point of question.
I was just going to comment, Jason, that there's no way we can be certain right now in primary prevention. It's going to be hard. It will take a long time. But to me, we don't actually know why the GLP-1s are so effective or why semaglutide is so effective. It outperformed its cardiac effects in diabetes better than you would have expected on A1C. It outperformed in secondary prevention compared to the risk reductions you would have expected from blood pressure and weight loss and A1C. And that feels a lot like the pleiotropic effects that we attribute to statins with hand waving. And as such, my best guess is that it's going to have important relative risk reductions in primary prevention. That doesn't make it true.
Right. No, appreciate the importance of the point. I think we are now at time. So thank you all. Congrats again to the research team and to the SMT, to Dr. David Rind and the whole team. And with that, I would like to transition to Dr. Ujung Lee from ICER, who is going to do the presentation of the evidence and the economic modeling.
Thank you. I'm going to do a presentation for the economic analysis part of this review, and my name is Woo Jung. I'm an Associate Director of Health Economics and Decision Modeling at ICER. Next slide. So Marina Richardson and I developed the cost effectiveness model in collaboration with Murray Phillips, and Murray also worked on the budget impact model for this review. All of us are ICER employees and we don't have any conflict. Next slide. So in this analysis, we compared injectable semaglutide, oral semaglutide, and tirzepatide added on to lifestyle modification compared to lifestyle modification alone. And this analysis focused on the same population as in the clinical assessment. Next slide. So before diving into the model, we would like to give a sense of unmet need for obesity based on absolute and proportional EVLY shortfalls. So the absolute shortfall for obesity, as you can see here, is about 6 years, which means that patients with obesity on lifestyle modification alone live 6 fewer equal value life years than they would without the condition. And the proportional shortfall indicates about a 20% loss in EVLYs. And these shortfalls were a little bit higher than other chronic diseases with a relatively low mortality, such as osteoporosis and high cholesterol. and was much lower than the condition like multiple sclerosis. Next slide. Next slide, please. For this analysis, we used a Markov model with a lifetime horizon, and base case results were estimated from the healthcare perspective with a modified societal perspective as a scenario analysis. Next slide. Baseline characteristics of the model population were drawn from real-world studies of individuals who are currently using obesity medications. So the model population had an average age of 46 years, with approximately 80% female, and the mean BMI of that population was approximately 38. Next slide. Our model was designed to simulate the treatment effects on BMI and its downstream impact on preventing the onset of obesity-related outcomes. And we chose the outcomes based on clinical evidence, expert input, and public comments. So in the model, patients will enter the model in a non-diabetic health state, and over time, they could develop one or more obesity-related conditions and progress to a more severe health state. Some patients could develop diabetes and transition to corresponding diabetic health states on the right-hand side of the model. And patients could develop multiple obesity-related outcomes within a cycle or may die from any health state. So as you can see in this model structure, chronic conditions with lasting impacts on mortality or disease pathways such as type 2 diabetes, cardiovascular disease, end-stage kidney disease, and cirrhosis were modeled as distinct health states. Additionally, obstructive sleep apnea or OSA and knee or hip replacements were tracked within each health state to capture their associated quality of life decrements and additional cost. And lastly, within the cardiovascular disease health state, we tracked specific subtypes such as MI, stroke, heart failure, and other types of the cardiovascular disease to capture their distinct impacts to the extent possible. Next slide. We made several assumptions. First, we assumed that the included obesity-related outcomes, as well as the direct impact of BMI on quality of life, independent of those modeled outcomes, can reasonably capture the main clinical benefits of these interventions. These interventions, of course, have broader effects, but the selected outcomes are those that are mostly likely affected by weight loss, and we think that they have most impactful. They have most impactful on health outcomes and cost. We also assume that the direct cardiovascular effects of these medications in patients with diabetes can be extrapolated to the model population with obesity. And I'm going to show you what estimates we ended up using in a later slide. We also assume that the treatment discontinuation patterns will mirror what was observed among the trial's ITT population, and patients remaining on the treatment during the trial period will remain on the therapy for the duration of the model. These assumptions were made because one, obesity is widely recognized by clinical experts as chronic condition that requires long-term treatment. And two, like we discussed, although some earlier real-world studies suggested low persistence with these medications, data to really accurately model long-term treatment patterns and associated outcomes remain limited. And lastly, experts have noted some recent improvements in treatment persistence, particularly following the resolution of major barriers such as drug shortages that might have influenced earlier study results. And lastly, all patients were assumed to reach weight loss observed in the trials within the highest dose. Although multiple dosing options exist and individual dosing may vary, clinical practice typically targets either the maximal effective dose unless limited by tolerability, or the dose that results in appropriate weight loss if it is lower than the maximal dose. Next slide. Next slide, please. Okay, so I'm going to talk about some key model inputs. So first, the percent change in body weight from baseline for each treatment was taken from the ITT populations of relevant clinical trials or their meta-analysis. We captured both weight loss by year 1 and by year 2 from those trials. And from year 2 onward, BMI remains stable to reflect sustained weight maintenance with continued treatment. Next slide. In terms of modeling the risk of obesity related outcomes that I mentioned previously, we use direct treatment effects on these outcomes beyond those explained by BMI whenever data were available. So starting with type 2 diabetes, we first estimated the probability of developing diabetes among those with obesity receiving lifestyle modification alone based on several studies. We then applied direct treatment effects on diabetes from relevant clinical trials listed here on the slide to adjust the diabetic risk for each intervention arm. Next slide. For cardiovascular risk, we again estimated the annual risk in the competitor arm using the Framingham risk prediction model. And then for the intervention arms, we applied direct cardiovascular effects of the interventions based on the relevant clinical trials that Dr. Lin mentioned in the clinical section. Next slide. For the remaining obesity-related outcomes, there were no data on direct treatment effects, so we varied risks based on the established associations with BMI or other relevant risk factors based on the literature. So for end-stage kidney disease, we estimated incidence rates by applying BMI-based risk multipliers to the US general population rate. And then the risks of cirrhosis and knee or hip replacements were modeled in a similar way. And then lastly, for OSA, we adjusted the expected prevalence over time among the model population using odds ratios for the prevalence with regards to BMI. Next slide. So for each of these obesity-related outcomes that we modeled, we applied condition-specific mortality to capture their effects on life years. The US general mortality was used as a proxy for baseline mortality among those without these conditions. And then as patients develop obesity-related outcomes, we applied excess mortality associated with each of these conditions, as well as the probability of immediate death following acute cardiovascular events. Next slide. In terms of quality of life, age-specific utilities from the US general population were used as baseline values for individuals without comorbidities and with normal BMI. And as patients develop these outcomes, we applied utility multipliers to capture their ongoing impact on quality of life. And we also applied short-term utility decrements to capture acute events. We also included BMI-related utility decrements not captured by the modeled outcomes, assuming each 1 unit decrease in BMI reduces utility. 1 unit increase in BMI reduces utility by 0.006. And finally, we included one-off quality of life decrement associated with severe GI side effects. Next slide. So in terms of the drug cost, injectable semaglutide and tirzepatide are already available in the United States. So we obtained their latest net prices from SSR Health. And we wanted to note that this net price from SSR Health already accounts for a proportion of patients using direct-to-consumer option available through NovoCare or LillyDirect. For oral semaglutide, which is not available yet for weight loss, we assume the same price as injectable semaglutide. Next slide. Non-drug healthcare costs mainly consist of healthcare costs attributable to the obesity-related outcomes that I mentioned. So as patients develop those outcomes, we applied ongoing healthcare costs attributable to each outcome. And additionally, one-time event costs for short-term events such as MI, stroke, or replacement surgeries were applied additively for individuals experiencing those acute events. And finally, we incorporated a one-time cost for severe GI side effects. Next slide. Next slide, please. Okay, so now let's take a look at the results. In the base case, Lifetime intervention acquisition costs were higher for all three interventions compared to the lifestyle modification alone. However, these were partially offset by lower non-drug costs during the lifetime horizon, resulting in only slightly higher total cost for these three interventions. Discounted QALYs and EVLYs were approximately 17 with these three interventions. Both higher than those with lifestyle modification alone. Next slide. Incremental discounted cost versus lifestyle modification alone ranged from about $77,000 to $89,000, with tirzepatide having the highest incremental cost. And for incremental QALYs and EVLYs, tirzepatide showed the largest gain, which is about 1.5, followed by injectable and oral semaglutide. Next slide. Given the recent announcement of the new Medicare price, which is $245 per month, we estimate the results using this price instead of the current net price to examine how it impacts the results. So as shown in the table below, total incremental costs compared to lifestyle modification alone were substantially reduced for semaglutide, and for tirzepatide it was negative, meaning that it has a cost-saving effect during the lifetime horizon. Next slide. At the current pricing, the cost per QALY and EVLY for these interventions range from about $56,000 to $75,000, which was below the commonly used cost-effectiveness threshold in the United States. Next slide. And at the new Medicare price, the incremental cost, the cost per QALY and EVLY were substantially lower compared to the current price for semaglutide, and for tirzepatide, the treatment was more effective and less costly. Next slide. In one-way sensitivity analysis, we found that the most influential parameters were the treatment effect on BMI achieved by year 2, as well as the quality of life change associated with BMI independent of model outcomes. And please note that these results are based on the current pricing, and this tornado diagram is specific to injectable semaglutide, but the findings were consistent for the other two interventions. Next slide. In the probabilistic sensitivity analysis at the current pricing, all three interventions were nearly 100% likely to be cost-effective at the thresholds above $100,000 per EVLY or QALY. Next slide. We also conducted several scenario analyses, and we'd like to present a few of them. First, we conducted a modified societal perspective, which includes productivity costs associated with the modeled obesity-related outcomes. And we found that the increased treatment acquisition costs with these interventions were partially offset by productivity gains, reducing the cost per EVLY or QALY slightly compared to the base case. We also ran some subgroup analysis based on the baseline BMI, using BMI subgroup-specific parameters to the extent possible. And as you can see, we found that these interventions were generally cost-effective across a range of BMI cut points at baseline, although there was slightly greater cost-effectiveness in patients with higher baseline BMI. Next slide. Our analysis has several limitations. First, because of limited long-term data, we assume that weight loss as well as direct cardiovascular or diabetic effect observed in the trials will maintain throughout the treatment duration. However, the durability of benefits are uncertain. Also, the model may not capture all of the treatment effects because some outcomes beyond those modeled could also contribute to additional value. But at the same time, I want to highlight that there is a risk of overestimating the benefits due to potential double counting of the impact of modeled outcomes. And also, as discussed in the clinical section, we have uncertainty in direct cardiovascular effects for all of the drugs in different degrees. And additionally, treatment discontinuation followed clinical trial patterns, but as we discussed earlier, treatment persistence in the model may be different from real-world levels, And if it was higher than real world levels, it'll lead to higher estimated treatment benefits and higher cost. And finally, there are uncertainties around the impact of this newly established lower price for Medicare on the prices for other payer types and who will be able to have access to this treatment at the lower prices. Next slide. So building onto the cost-effective result, we estimated potential budget impact of these interventions to facilitate discussion around affordability. And in this analysis, we assume that all eligible patients in the United States initiate the treatment over 5 years. And please note that this uptake level is not based on the likely expected or real-world uptake. Next slide. We first estimate the size of the eligible population based on the published data, and then the population was defined as US adults with obesity or overweight with comorbidities, except for type 2 diabetes, and not currently on anti-obesity medications. We also derived drug cost and non-drug cost for the first 5 years from our cost effectiveness analysis. Next slide. So at current pricing, our analysis estimated that a cumulative budget impact will be about $7,000 per patient in year 1, and it'll increase to about $17,000 by year 5. And we also found that fewer than 1% of the eligible patients could receive the treatment over 5 years before the ICER's potential budget impact threshold is met. Next slide. When we assume that this new Medicare price would apply to all eligible patients in the United States, the proportion of eligible patients who could be treated before reaching the threshold increased, but it still remained less than 1%. And this result also suggests that even though tirzepatide was cost-saving at this price from a lifetime horizon, it does not fix the budget impact in the short run. Next slide. We received several comments on the economic analysis. First, we received feedback that earlier stages of liver fibrosis should be considered because semaglutide has been recently indicated for non-cirrhotic MASH and therefore may reduce healthcare costs and improve outcomes associated with MASH. After the team discussion, we decided not to model MASH because we believe that stage 2 or 3 fibrosis primarily serve as risk factors for progression to cirrhosis, and they are not generally clinically apparent themselves. Next slide. We also heard that by applying a fixed annual budget impact threshold and relying on non-empirical uptake assumption, we are limiting the utility and practical relevance of our budget impact analysis. And here we would like to clarify that our analysis, our potential budget impact analysis, is intended to provide an alert if anticipated cost for overall healthcare system has the potential to exceed specific growth targets. We will definitely discuss during this meeting on the intended use of these medications, and it'll help determine whether we will issue an alert in the final evidence report. Next slide. So in conclusion, these drugs are expected to be cost-effective based on the commonly used thresholds at the current net price or assumed price for oral semaglutide. However, short-term potential budget impact is expected to be high. And at the new Medicare pricing, the drugs are even more cost-effective, although concerns about affordability still remain. Thanks. That's it for my presentation. I'm happy to take questions.
Thank you, Dr. Lee, Woo-Jung. That was fantastic. And I guess I just want to give you a specific shout out on behalf of our panel. I think for this price news to come out 6 days before the public meeting, the fact that you were able to recalculate a lot of these things, these models are so complicated, is really astonishing. And we're very grateful for all of your expertise.
Thank you.
Thank you. Don Kreis.
Thank you. And thank you, Dr. Lee, for that very lucid presentation. I think the most interesting thing that I read in any of the materials that I reviewed prior to today's meetings was embedded in the comments, and it was a comment that was made by the representative, or it was made by Novo Nordisk, and this was embedded in their comment number 8. It says, Novo Nordisk notes that to meet ICER's budget impact threshold of 880 million, weight management drugs would only be affordable if they cost less than $10 annually. And my question, and I'm not sure if it's for Dr. Lee, maybe it's for the representative of Novo Nordisk, who's going to be part of the policy roundtable, but as the sort of lawyer and patient family representative in the crowd, and therefore a non-expert, my question is, well, why not? When we do public utility rates, we calculate a revenue requirement for every utility. It's a function of its annual operating costs plus a reasonable return on investment. Well, whatever that revenue requirement would be for a company like Novo Nordisk, if you divide that among every patient who could take the drugs, you would get down to a price that looks a lot closer to $10 than, you know, $6,000 or $8,000 or even $3,000. Why can't we do that? Like, what is it about our system? I realize that ICER is going to put out an access and affordability alert, but maybe this is a special case that goes beyond any of that. Obesity is I think, a unique phenomenon in our economy because it's essentially a natural response to our weird food economy. So why can't we, either through margin rights or something else, why can't ICER just say, yeah, the price of this drug really should be $10? And maybe if companies like Novo Nordisk can't do that, then maybe we just need to take it away from them. I realize that's a pretty bold question, but you know, I'm the guy that isn't afraid to say the emperor is naked.
Don, thank you. And I will jump in with Jason with your blessing to just
Thank
be
you.
like,
Yes, I was hoping someone would. Thank you.
I really appreciate that energy, Don. What I appreciate about that energy is that we are faced with something unprecedented with this question, because having a highly effective, and I'm not trying to bias the votes that are still to come from this independent panel, but a highly effective medicine for a large population invites questions about novel policy solutions. So I'm going to bring some of that to the conversation later, but I can't miss the opportunity to also be sure that we're clear that the use of the threshold that ICER develops for its budget impact is not meant to then calculate the price at which. It is truly meant to send a signal to the system that we are likely to have an affordability problem. So what are the policy solutions that can achieve that? If some actors in the system think the policy solution is a very low price, that is fair game for discussion, but it's not the intention of ICER to use our budget impact threshold to then calculate the price at which. And so that's okay to have a philosophical difference about how to apply that, but I wanted to be clear about how we use the budget impact threshold to invite conversations about affordability. And John, thank you for some points that I will absolutely bring up in the roundtable.
Thank you, Sarah, for making that important distinction, especially today. This distinction is so important with this issue. Austin, Dr. Fract.
Thank you. I'm delighted the conversation's already turned to the total sort of budget affordability issue. I think that's, to my mind, the most critical thing about all this, although all the other areas of this issue are important. And you know, what I'm thinking about is just, and I'll just say this as a statement, but to the extent you know, Dr. Lee or anyone else can inform this, is how to translate those kinds of numbers to what people will see in their premiums. Not everyone pays for healthcare through premiums. I understand that some are tax financed, but you know, just bring it down to the personal level. And you know, I can really quickly try to rough this out in my head, but it's awfully crude, and I don't know if we can speak to that in this meeting.
If I can answer this question, I'm pretty sure that each payer have different way of, you know, translating this incremental budget impact to, you know, how it'll affect the premium for each individual. But in our budget impact, we didn't present that outcome. But in our budget impact, we typically also try to estimate per member per month or per member per year premium increase, which will be available in our platform called ICER Analytics. And so you'll be able to see that, given that, the incremental budget impact is really high, and there is primarily because of the big eligible size of this population, I guess the per member per month would be much higher than our typical reviews, but that will be available, and that could be used as a proxy for how much of an increment there will be for the premium per month per member.
I think I'm seeing Jason, you might be on mute. I'm not sure if you're. Yep, I think Steve's next. Jason's struggling.
Oh,
with
I'm
the
on mute. I'm sorry. I thought Steve was
That's
on.
okay. No, I was
You
gonna
would think
just
5 years into the Zoom generation, I'd get this right. Sorry, Steve Kogut, please go ahead. Sorry about that.
All right, thanks. Yeah, I do want to back up to the cost effectiveness analysis. Generally, we're evaluating medications that have an ICER that suggests maybe they're not cost effective, or the long-term value is not perhaps ideal. And in those instances, I try and think about ways, well, what are the arguments for, how the analysis could have favored the product? And in this case, it's in the opposite direction. And I've been thinking, well, what are the sort of arguments for, why this ICER result, or this incremental cost effectiveness ratio, might be a bit generous? It does differ from the CEA that the manufacturer did a few years ago. So Novo's own CEA of semaglutide versus lifestyle had a cost effectiveness ratio which is almost exactly double what the ICER analysis found. And I think the key difference between those CEAs was the Novo-sponsored CEA capped treatment benefit at 2 years. And in the ICER model, not only were patients assumed to continue treatment indefinitely, but it seems like the worst a patient could do in the sensitivity analysis for semaglutide was a 12% weight loss. So, again, maybe the ICER model, in my mind, is a bit overly generous to the treatment, and I'd be interested to hear your thoughts about that, and maybe if you want to make any counterpoints to what I said. And again, awesome job on the model. I thought it was really complex. You must have had a 6-foot wide computer monitor to keep track of everything. So, right. But let me be quiet.
I thankfully have 2 monitors, so that was helpful. So in the report, there is an uncertain prior economic model section where I try to explain the reasons for the discrepancy between our model results and the other models' results. And so you will see my explanation compared to our other manufacturers or other models out there. I think the key difference, number one, is the price assumption. So in the previous models, drug costs were based on the list price, so it was almost a double than the price that we use. So that definitely reduces our cost effective ratio. And then I think another reason is because we incorporate direct treatment effects on diabetes, type 2 diabetes, and cardiovascular effect. And then those 2 parameters are pretty impactful, especially the direct impact on diabetes. That's pretty impactful. And then I think number 3 is that we incorporate more obesity-related outcomes than the other models, and so that'll also, that'll have some impact on the larger treatment effects. And then, like you said, I think it has something to do with treatment discontinuation assumption. Given that I think for this obesity medication, we pay kind of upfront for later benefits. And so if patients discontinue this treatment earlier than I didn't do this analysis, but I assume that the cost effective ratio will increase. So because our assumption is that, patients follow the treatment continuation patterns that we observe in the ITT population, and then after year 2, they are assumed to continue on their treatment and have lifelong benefit from the treatment. And I think that'll probably contribute to higher cost effective ratio.
I just want to jump in.
Yes,
because we looked at this in a prior report, and the 2-year model done by the manufacturers actually makes their drugs look better in some ways, because it makes assumptions that may not be fair about the timing of gain and loss of benefits, particularly cardiovascular benefits. So actually, while I think it's exactly true that just looking at 2 years should make it look worse, I don't think that happened in that model. And I don't think that's what you're seeing, Steve. I think what you're seeing is when you double the price, you kind of have the cost effectiveness. I mean, not exactly, but that's sort of what was going on there, I think. And the 2-year model, we felt pretty strongly the last time we did this, that there was no fair way to look at 2-year outcomes when everybody sort of thought it needed to be ongoing therapy. So just to give one example, we don't actually know what happens to people's cardiovascular risk when you've dropped their weight by 16% and you stop a drug, and then over the next year, they go back up to their prior weight. Do you assume that the cardiovascular risk stays low and only increases with the weight increase, or does it jump way up to where it was before, or does it go even higher because it's a really bad idea to be rapidly gaining weight? We don't know the answer to any of those things.
Thanks, that's helpful. I'll still cling to my sword in that the efficacy that was in the sensitivity analysis might have dropped a little bit below 12%. But I see your point on the other matter. Thanks.
Thank you both. Tara, Dr. Lavelle, you have a question or point?
Yeah. Thanks for that, both of those great presentations. My question is about the budget impact thresholds, and I'm just wondering if either Dr. Lee or Sarah, you could remind us how that threshold is, how you derive that, and yeah, just remind us of what it represents.
Sarah, do you want to take that question?
Yuzhong, I was hoping that you had all of the numbers memorized, as I do not. And Tara, I will put the link in the chat for exactly the inputs that we use for the threshold. But the idea is we calculate it based on how much of the pie that we allocate to drug spend, how fast we allow that segment of the pie to grow. And it's about so it has to do with how many drugs are approved each year. And so we calculate all of that. And then it's basically saying we don't want it to grow faster than twice the rate of the overall growth in healthcare spending. And I'm looking at Yuzhong to make sure that that is like generally correct.
That's generally correct. Yes.
Okay, fantastic. And that's how, and so we recalculate it each year because it depends on the rate of growth of healthcare spending, how many drugs are approved. So that contributes to how much the pie grows, that slice of the pie. But it's this idea that when we have that slice of the healthcare spending pie grow faster than twice the rate of healthcare cost overall, premiums go up in such a way that payers start to make decisions about access and affordability that has harm. And so that's like the general spirit of it, but we'll make sure you get the exact calculations, which are on the website.
Got it. All right. Thank you. And I guess just like one takeaway from that then, based on your answers, I think that, I mean, one of the concerns with all of this, right, is that we're looking at decisions that insurers are making based on one drug and based on its total affordability over a population. And we can say for this drug, yeah, that's not affordable, and that's, you know, a big problem. But then we're not looking at the collective impact of all the other drugs that have been paid for by insurers, right, over, let's even just take the last year, and that affordability problem. But we don't ding any one of those drugs to say, hey, like, you just put this over the threshold, like, you know,
sure,
you can't do that. You should be, you know, you should reduce your price. So it's just that we've taken one very cost-effective drug and we said, you're just too expensive, we can't pay for you. Instead of saying, looking at all of these other very not cost-effective drugs,
sure,
and saying to any one manufacturer, like, hey, like collectively, like, you guys are all making everything really too expensive. So it's sort of like, when you look at just one piece of the pie, right, we're having a very, you know, a legitimate conversation about affordability, but that piece of the pie is not looking at this whole other huge piece of the pie, right?
Tara, I really hear your point, and I do want to make the point that because we're calculating it based on all of the spend for all of the drugs, we are accounting for some of that. But your point's really important, and I made this point yesterday at the Massachusetts cost trend hearing, is that because we have been overspending for value in many cases for drugs that this group has evaluated and deemed low value at the price picked by the manufacturer, it's about 70% of the time, then we find ourselves in the position where we have a cost-effective drug for a large population and we panic. So I'm going to bring that to the policy roundtable. Please be sure that that tension is real. But it's almost like, okay, tough, this is the situation we're in right now. But I don't want to diminish the importance of your point. We'll bring that through, but it is the reality of our system right now that we're facing this affordability challenge.
And it's just a bigger picture of a very broken system that puts us in this position. Yeah. Well, thank you.
Thank you, and thank you to everyone on the panel for such a vigorous conversation and really important questions. Again, our gratitude to the ICER research team for a fantastic clinical evidence and cost effectiveness analysis and presentations today.